Good afternoon, everyone. My topic will be on the guidelines and recent advances in the management of amblyopia. To start with, I don't have any financial interest in this presentation. Over the past decade, people have been mulling over a lot of changes. Occlusion has been the mainstay of treatment in case of amblyopia, and the role of near activity has been questioned, and pleoptics, vision stimulation and drug therapy have shown various interest throughout the world. Patching has been the mainstay of for the past 250 years, and recent studies have shown a better understanding of how to tailor the therapy according to the age of the child to achieve the best outcome while minimizing the negative emotional impact. And traditionally it has been the dosage has been tailored according to the age of the child. 1 full day of occlusion has been prescribed for 1 year of age, and with 1 day of initial way of doing occlusion. But it has its own drawback. There has been controversies regarding the hours of patching, complex issue always, and there has been associated physical as well as psychological stress factors as well. And recent trends in the treatment have been developed from the PDIG study and evidence-based practices. The PDIG is the expansion for Pediatric Eye Disease Investigator Group. It's a collaborative network which was formed in 1997 in the USA under the National Eye Institute, part of National Institute of Health. And it's a multi-centric clinical research in strabismus, amblyopia and other disorders that affects children. Let us see some case examples to have a better understanding of the management of amblyopia. Case number 1. A 6-year-old girl came for a first-time eye checkup with no strabismus, gross stereopsis. Ocular examination was normal. Cycloplegic refraction showed this value. Subjective refraction, the child accepted this glass prescription after cycloplegic refraction. The diagnosis was compound hypermetropic astigmatism with anisometropic amblyopia in the left eye. The American Academy of Ophthalmology have given an amblyopia treatment guidelines. It says that if the child is amblyopic, full correction have to be given, whatever be the type of refractive error, except in hyperopia without esotropia, where symmetric undercorrection can be done. The child was asked to come for a post-mediatic test, and this was the acceptance. The vision was 6/24 in the left eye. There were some points to ponder in this patient, whether occlusion should be prescribed same time as refractive correction, whether there is a treatment effect over time in varying the refractive correction alone, or any difference between anisometropic and strabismic amblyopia. The PDIG had studied the treatment of anisometropic amblyopia with refractive correction alone in previously untreated 3 to 7-year-olds with anisometropic amblyopia, and these children were treated with spectacle treatment alone without occlusion. And the maximum improvement in the amblyopic eye visual acuity, the proportion of amblyopia that results, and the time course over which the vision improves were also studied. And the study had shown that the vision improved by a mean of 2.9 lines, and the improvement was better when the presenting visual acuity was better. Wherein when the presenting vision was between 20/40 and 20/100, the improvement was better, whereas when the presenting vision was worse than 20/100, the amount of improvement was slightly worse. And this is with refractive correction alone, without occlusion. And 92% of maximum improvement was achieved by 15 weeks after refractive correction alone, and the child has to be monitored at 4 to 6 week intervals, and we can wait for until 2 consecutive visits with no improvement before starting occlusion. The improvement also seen in cases with strabismic amblyopia. So the main clinical implications are only some children will need occlusion, and majority of the children may not need occlusion at all. If occlusion is needed, with refractive correction for the initial 1 or 2 months, the child will have better visual acuity during the time of starting of occlusion, and possibly we can get a better compliance. And it is always advisable to start one new treatment at a time. This patient, when the patient came to us for a follow-up at 1 month, let us, if we assume that the left eye visual acuity improves to 6/18, what should we start with? Whether patching or atropine, or what is the optimum dosage of patching, and if atropine, what is the dosage, and how long should we do it? The PDIG had studied the patching dosage comparison for moderate amblyopia, that is between 6/12 and 6/24, and they had found out that patching for 2 hours and patching for 6 hours almost produce the same results, 2.4 lines and 20/32 mean acuity at 4 months. There was no difference between patching for 2 hours and patching for 6 hours in case of moderate amblyopia. So it is advisable to start patching for initially at 2 hours per day only. And in case of severe amblyopia, the PD had shown that patching for 6 hours and patching for full time virtually produce the same results. So patching for 6 hours is almost equivalent to patching full time. And in case of 3 to less than 7-year-olds in children with amblyopia, decreasing the patching duration may increase the implementation of treatment and improve the compliance. In case of moderate amblyopia, start with 2 hours per day, and in case of severe amblyopia, start with 6 hours per day. Full day of patching produces the same results as with 6 hours of patching per day. If inadequate response, then we can increase the intensity or prescribe atropine as well. Patching versus atropine was also studied by the PD, and essentially the improvement was the same in amblyopic eye visual acuity when patching and atropine produced the same results. And atropine was well tolerated, and very few patients reported side effects. And weekend atropine is another good alternative, and it produced the same results as compared to daily atropine. And visual acuity improvement was similar to 2 and 6 hour patching regimens. And it is always advisable to provide written instructions regarding possible side effects when prescribing atropine. The second patient was a 10-year-old girl who failed school screening examination. The visual acuity in right eye was 6.6 and left eye was 5/60, and she had a 20 prism exotropia and intermittent exotropia, and the ocular examination was normal. Cycloplegic refraction showed 1.5 sphere in right eye and compound myopic astigmatism in the left eye with a visual acuity best correct visual acuity of 6/36. PD had studied the effect of patching and occlusion therapy in older kids also, and amblyopia improves with optical correction alone in 25% of cases, and this improvement was seen mostly in the 7 to 13 year age group. Additional improvement in 7 to 13 years age group, additional improvement with patching or atropine regardless of whether prior treatment or not. Whether the child had received prior treatment or not, occlusion or atropine therapy gives better results in the 7 to 13 years old children. And 2 hours of daily patching with or weekend atropine alone were both effective. And response to treatment was seen irrespective of the severity of amblyopia and irrespective of the cause of amblyopia. And whereas in 13 to 18 years age group, improvement was seen only if the child had not received any previous treatment. And if the child had received previous treatment, the improvement was not seen much in the 13 to 18-year-old age group. The third case was a 5-year-old who presented us with complaints of watching TV from close distance and holding toys close to the face. The ocular alignment was normal, and the ocular examination was normal. Cycloplegic refraction showed high myopia. In case of anisometropic amblyopia, treatment of bilateral refractive amblyopia with spectacle correction alone increases the binocular visual acuity in children aged 3 to 10 years old. And most of the children improve to 20 to 25 by 1 year of treatment, and additional improvement could potentially occur beyond 1 year. Case 3, initially the best corrected visual acuity was 6/36 with correction, which improved to 6/18 by 2 to 3 months. The fourth patient was a 7-year-old girl, complains of squinting since 3 years of age. Visual acuity in right eye was 6/18 and left eye was 6/6. Orthoptic evaluation showed 25 prisms of esotropia with accommodative target. The dynamic and cyclo refraction the alignment has changed. The cyclo refraction showed hypermetropia. It's an accommodative esotropia with strabismic amblyopia in the right eye. And patch of left eye with near activity for 4 hours a day. On 3 months, the best corrected visuality in right eye was 6/9 and left eye was 6/6. And prism quarter showed prisms of esotropia. Case number 5 was a 6-year-old with squinting of eye. The patient gave a history of pinkish upper lid swelling at birth, which regressed after steroid injection at 6 months of age. At presentation, the visual acuity in right eye was 1/60 and left eye was 6/6. And on examination, the child had right eye ptosis with regressed hemangioma, and the rest of the ocular examination was normal. Cycloplegic refraction showed these values. And diagnosis of right eye sensory deprivation amblyopia was made, and the visual acuity was 1/60, and trial of patching was started. An amblyopia treatment the patching treatment can be made interesting by advising near activities in which the child may be interested, and this can improve the compliance as well. And the studies have shown that 25% of after treatment, 25% have a drop in visual acuity up to 1 year after treatment, and minimum follow-up of 1 year is required after cessation of therapy. And tapering of the occlusion dosage reduces the recurrence risk, whereas then studies have shown that abrupt stopping of patching regimen definitely increases the recurrence rate. When to stop occlusion? When the visual acuity becomes equal in both eyes, it is always advisable to taper the occlusion and stop. And even if the visual acuity doesn't improve, then if there is no progress even after 3 months of good compliance, then it is time to consider tapering the occlusion. And occlusion should be maintained at least 8 years of age to prevent recurrence. And minimum amount of occlusion with near vision enables maintenance. And once recurrence occurs, it is even more difficult to treat. Compliance is one of the main factors. One study have shown only 48% of the patients show good compliance. Parental motivation is very important, because unless the parents are motivated, the child will not be made to wear the patch. And written information, and there are support groups which can help the parents. There are online support groups which can help the parents to improve with the compliance. And attractive patches in various designs also improves the compliance in very young children. Improving compliance also, there are various methods to improve the compliance, like gradual increase in the hours of patching. In very young children, it is difficult to prescribe long hours of patching. So gradually we can start with lesser duration of patching, and then it can be gradually increased. And occlusion dose meters can involve the children, and they can create some amount of interest in the occlusion. Occluded contact lenses or other options. Sudden eyelid closures in very uncooperative or mental children, this is also another option. And near activities, pediatric studies have shown that near activities, in prescribing occlusion therapy for 2 or 6 hours with at least 1 hour of near activity produces a better result. And intensive binocular computer-based near activity in previously non-compliant patients have shown very good improvement. And some of the recent advances, the IBIT is interactive binocular treatment. It's a virtual reality based system developed by the Queen's Medical Center in the UK. It's based on the principle of binocular imaging at the same time, and the more interesting image is projected onto the amblyopia eye, and the child is interested in seeing the more interesting part, and this stimulates the amblyopia eye, and it has shown early response has been very good. Longer results are awaited. And this is another test, another modality of treatment, the repetitive transcranial magnetic stimulation, the RTMS. The recent studies have shown that plasticity in the adult amblyopic visual cortex, and this treatment has been used to treat various neurodegenerative diseases even in the adults, and this has also shown very good in the early stages. Drug therapy has been shown to instill some interest on and off in various schools of thoughts, and levodopa and carbidopa and cytocolin are all drugs which are used to stimulate the cortical neurons in case of Parkinsonism, and these drugs have been shown to elicit response in amblyopic patients, and long-term effects are still awaited. And we can expect some newer modalities of treatment in the future, including the transcranial magnetic stimulation, anodal current stimulation telescopes, drug therapy, and refractive surgery. Few take-home points. Anisometropic amblyopia, initially start with spectacle correction alone and wait for a little bit of improvement in the visual acuity before starting occlusion therapy. Advise patching after 1 month if still there are more than 2 lines of difference between the eyes. Moderate amblyopia start with 2 hours a day, and in severe amblyopia advise 6 hours a day of patching with near activities. Older children also respond to amblyopia treatment. Atropine can be used for penalization, especially in children who are not COD compliant, and weekend atropine still produces as good a result as daily atropine. In isometropic amblyopia, spectacle correction alone produces very good improvement over the first 1 year of using spectacles. And considering the prognosis for improvement, ametropic amblyopia gives best improvement, followed by anisometropic and then arabesmic. And expect poor improvement in spite of good compliance in sensory amblyopia following vision deprivation in infancy, especially unilateral congenital cataract. Thank you.